Do you think that if patients took a breath at the front end, 5 days a week, a couple weeks, that they might be more committed to their choices?
They could be, especially if they have ownership over them. And I hate the word
Mhm.
compliance. I mean, I hate jargon anyway, but I feel like the word
Okay.
compliance just needs to get out of medicine because it means that, at least in the doctor's eyes, that the patient's doing exactly what you want them to do. And yet every doctor I know would not be a compliant patient necessarily, right? They're going to take their time. They're going to get multiple opinions. They're going to look at all their options.
Hi, I'm Maureen Shaffer, and welcome to the Message Engineers Show. Today, I am delighted to have with us Andrea Wilson Woods, who is an award-winning author of the best-selling Better Off Bald. She is also the founder of Blue Faery, which is a nonprofit established in her younger sister's honor. Her younger sister passed at age 15 of liver cancer. And if that wasn't enough, Andrea is also the CEO and co founder of a digital health company called Cancer University. Welcome, Andrea. So I usually start with something I call define the word warm up, and I think you've occupied so many really interesting roles in currently and kind of in the past that I would love to hear your definition of patient advocate.
Oh, well, it's right there in the word, right? So just the word advocate alone, it's really fighting for what you want, a cause or a belief. And so for patient advocates, it's fighting for what that patient wants. And it's also educating them to all the choices they have because oftentimes when you get a serious diagnosis, you don't realize that you have options.
Mm. That's a that's a great point. There's a tendency sometimes, I would imagine, for like fear to take over and thinking you have to go down one specific path, but medicine's constantly changing.
It
And
is. And what I hate to see, and I still see it too often, is you get this diagnosis and I kind of blame doctors. There's this sense of urgency. You've got to do this right now. You have to do this therapy that right now, right now. If it's life-saving surgery, that's one thing. Or if it's a way to put you out of pain, so to give you a prescription for pain, that's fine. But to rush into a whole treatment that might be taking over the next 6 months, year, 2 years, 3 years of your life, it,
Mhm.
it's dangerous. And that's what I feel like a lot of patients don't realize because I'm thinking of a patient right now. If you go down one path and you don't get a second opinion and you don't look at all the options, when the time comes and you're ready to do so, those other options may no longer be available. So if you're looking at clinical trials, but you've already had X, Y, and Z
Mm.
treatments, then you won't be eligible. And I've heard from more than one cancer patient, you need to take your time. You know, again, if there's a life-saving surgery that needs to happen, years ago my appendix burst, that was a life-saving surgery. That's different. But if it's a diagnosis and you can take a step back and take the time to get a second opinion and and then really have a plan, the outcome is usually better.
I would think it's interesting too, because one of the things that comes up a lot of times is, right, like you said, this urgency. And there's also I tend to say that if you have a hammer, everything looks like a nail. And I've done it, right? If I ask a surgeon how to
That's
solve a
right.
problem, it's
Cut it out.
surgery. If you ask an oncologist, perhaps, someone who does radiation therapy, how to solve a problem, it's right, chemo and
Yeah.
radiation therapy. And there are guidelines, right, that direct folks one way or the other, depending on a whole host of factors that are incredibly complex. But I think there is, yeah, that's a great point about taking that time at the front end to really understand what you're doing. That is, and taking a really thoughtful approach. I wonder what you think about, there's a lot of talk about compliance. And so, for example, one of the things that I know about head and neck cancer is
Oh
that
my
1 out of 5 patients are non-compliant with a radiation therapy, and it affects, doubles the recurrence rate. It's like 1 percentage point a decrease in survival with each kind of day that passes with non-compliance. So there are other data out there, and that's probably 5 years ago kind of data. Do you think that if patients took a breath at the front end, 5 days a week, a couple weeks, that they might be more committed to their choices if they understood?
They could be, especially if they have ownership over them. And I hate the word
Mhm.
compliance. I mean, I hate jargon anyway, but I feel like the word
Yeah.
compliance just needs to get out of medicine because it means that, at least in the doctor's eyes, that the patient's doing exactly what you want them to do. And yet every doctor I know would not be a compliant patient necessarily, right? They're going to take their time. They're going to get multiple opinions. They're going to look at all their options. I like
Mhm.
that you mentioned head and neck cancer. My step grandfather was misdiagnosed with an abscess tooth, and small town, Arkansas, and it just kept getting worse. And finally, I kind of intervened, got him to a specialist at the University of Arkansas, got him to the top guy in the state. And yes, it was squamous cell carcinoma. He had a tumor the size of a lemon, but he waited so long to even get a second opinion that by the time the surgeon took that out, it grew right back. And my step grandpa had the wherewithal to say no to chemotherapy and radiation. He was supposed to start them. And I always say that patients, they may not realize it, they may not be able to articulate it in medical terms, but they know their bodies. And I was in the room when my step grandpa said, "No, I'm not doing it." And my stepmother and my step grandmother were really upset. I mean, this is his wife and his daughter. And they were like, "No, no, no." And I said, "No, no, no, you need to listen to him." And
Mhm.
he continued to go do testing. And the surgeon said it was the right decision because the cancer had come back so quick. He had never seen anything like it. So the chemotherapy and radiation would not have made a difference. And instead, he went into hospice and he had plenty of time to say goodbye to everybody. And he had this beautiful, peaceful death in his wife's arms in his own bed at home. You know, was he a non-compliant patient because he didn't do the radiation or chemotherapy? Some doctors might think so,
Mhm.
but he did what was best for him.
Yeah, I think it's interesting uh, because a lot of people talk about this idea of um, are you prolonging life? Or are you
Mm,
prolonging death?
yeah,
Right? And what's
yeah,
that quality of life that remains that you'll have?
yeah, yeah. I know a patient. He and his wife had a terrible oncologist. Live in a very small town. They live outside of a very small town in rural Texas. The oncologist, a general oncologist, comes to town 1 day a week, and he was terrible. And he wasn't a specialist in liver cancer, but they had a wonderful GI doctor who finally said the treatment is killing him, and it's not curative. So you have some decisions to make. And I thought it was so brave of them because they decided to stop treatment and he went into hospice. That general oncologist got mad, told his wife that she was killing her husband. That is awful. That's a terrible thing to say. And they had the most wonderful last year, almost year and a half. And in fact, he had to renew hospice twice because he didn't die. And he was living and they were doing things. I mean, 2 days before he died, he was doing yard work. He was doing so well. And there are studies that back this up, that patients often live longer in hospice than they would have on treatment.
Yeah, I find that really fascinating. I know people. My brother-in-law's mom did similar. She had cancer, beat it once, and then when it recurred, she was like, "I'm done."
Good for her.
That was worse than death. I'm not going through that again.
Yeah.
Uh, and yeah, I have to respect that. I wonder, you have this really unique point of view, right? From having from your sister, right? You're a sister to Adrienne, your parental role figure in a way,
Mm-hmm.
right? Taking custody of her when she was 8, as I understand.
Yeah.
Um, and as a caregiver. And I'm wondering, with that kind of really unique perspective, how do you, what did you learn, and what are some of the things that you see need to really shift when you give these stories about, oncologists, people making decisions and pausing at the front to think them through? I mean, what did you learn from that that's unique that we broadly need to understand and appreciate?
Well, my sister's experience was very unusual at the time because children her age did not get primary liver cancer, hepatocellular carcinoma. It was very much, especially 20 years ago, a cancer that non-North American males over the age of 50 got, because I remember that phrase exactly. So it was very unusual. And I would make very different decisions today because
Mm,
I knew from the get go that the pediatric oncologist didn't have a lot of experience with her cancer. But
mm,
but he pressed on us this sense of urgency, like, we've got to do this. And I didn't understand that the chemotherapy was palliative and not curative. He never used either one of those words with me ever. And by the time I got a second opinion, and by the time I actually was able to fight the insurance and get her transferred to UCLA, she had already undergone 4 rounds of chemotherapy that had just absolutely
wow.
decimated her immune system. I don't think there's any evidence that it actually helped extend her life at all. And so that's why I encourage patients now to get a second opinion right away. And we do help with that through Blue Faery. I encourage patients to take a moment to sit back and think about all the options. And for liver cancer, there are so many more options available now, but it's also very confusing because there are so many
Mhm,
options. And you made a really great point. Depending on that doctor's specialty, they're going to have a bias. And that's something that I help patients and families understand, and something that I didn't understand. Um,
mhm,
the role of a multidisciplinary team, and how important it is that, yes, you may have a multidisciplinary team, but you, the patient, or in some cases, if you want it to be your loved one, you're the captain of the team, not the doctor. You're the one in charge. I gave this speech recently for this conference where, I hear so much from patients and caregivers how these teams aren't acting like teams. And what I see is that even in the best tumor boards, they often operate like swim teams, which to me is not really a team. So, I mean, unless you're doing a swim relay, it's still not really a team, right? Because the swimmer is in their lane doing their specialty and
mhm,
focusing on their time, and they're not communicating at all with the other swimmers. And as much as I dislike football, I think that's a really good analogy for what a team should be like. Because in football, you can see right away when the communication breaks down. And even when you have the greatest of all time, like a Tom Brady, he can't be the best player on the team. He can't be the only one. There has to be someone that's going to catch that ball he's going to throw. So you
mhm.
really have to have a team that works together and communicates and keeps in mind that at the end of the day, the patient is the one in charge.
Yeah, I think. I love that analogy of the swim team, right? Because they all come with like the research they know, right? In their
Exactly.
lane, research they
Yep.
know, the meetings they attend, uh, and yeah, they're all very specialty driven. I'm thinking of all the conferences I've ever been to, right? AHA, the
Yeah.
American Heart Association, right? ACC, the American College of Cardiology. They're all like right down one lane, and then they become so deeply specialized, which is great in one sense. Then it's hard to kind of step back and extract that kind of across and build connections between those specialty silos, if you will.
They are.
Right.
They are silos. Again, even in the best tumor boards, they are very siloed. And that's very hard for patients and families to navigate. I mean,
Mm-hmm.
I remember with my sister, there was this moment during her third round of chemo that it was just very challenging. Like everything that could go wrong had gone wrong. And a scan came back, and the radiologist and the GI and her oncologist all disagreed about what they saw in the scan. And then they argued about it in the room in front of her. And then they turned to me and said, "Well, what do you think?" Because based on what they thought, they had different recommendations about what to do. And it was such a horrible feeling to be put in. I was like, okay, does she have an infection? Does she not? I don't know. And finally, I decided to go with the radiologist because I figured one, it's his job to actually read these things day in, day out. And
Mm-hmm.
two, his attitude was wait and see. And I felt like in that moment, that was the best thing to do because the last thing she needed was another medication in her body. And
Mm-hmm.
luckily, it was the right thing. She did not have this infection that the oncologist and GI were convinced that she had that showed up on the scan. She didn't. And but but for a family to be put in that decision when you're not a doctor, it's really hard. It's confusing. It's terrifying.
Yeah, absolutely. You don't have that background in medicine, and you haven't read.
Yeah,
I mean, when I hear my family ask me for help with things, I go
I'm
to the
sure they
guy. I
do.
go search, right. I go PubMed, fire up the National Library of Medicine, and I search for the clinical guidelines
Yeah.
for that society. And I start there, and then kind of work out from there. Um, and yeah, it's challenging, right? And for people who aren't part of this, or people who came up when there were different the hierarchy worked a little bit differently,
Yeah.
that can be super challenging. So one of the things that I find interesting in what you're talking about a bit, and I think it touches on this, is that I've heard the idea of, we've called people patients, right, as if they are their diagnosis for very, very long time, and other people
Especially in
are
certain diseases
advocating,
like
yeah,
diabetics,
and
right? Yeah.
mm-hmm, it's very, very true. And some people believe that to be disempowering. I hear other people suggesting it should be healthcare consumers. I hear other people pushing back against consumer to healthcare client, that we should see them a little bit more like, peers, or a little bit more as our customer, our client. And I'm wondering what your thoughts are around all of those terms. Should we, shouldn't we? What do you think?
I don't like consumer. I don't like consumer. Um, because people don't choose to be a patient. They don't usually want to be the patient.
Mm-hmm.
Um, I have not heard that feedback. Um, and I'm thinking about the doctors I know. I wonder what they would say. I just can't imagine them thinking of their patients as clients. But there's nothing wrong with thinking of them as human beings and as equals
Mm-hmm.
in that respect. Are they your academic equal, your intellectual equal? Maybe not. Um, are they a doctor? Probably not. But they are a human being, and so are you, and that's something to keep in mind. I remember I spoke to this doctor a couple years ago, and he's an oncologist, He specializes in lymphoma. And then he got diagnosed with lymphoma.
Mm.
And he said he had
Wow.
no idea what it was really like until it happened to him. And his frustration with his patients was that he felt like they weren't listening or paying attention when they first got the diagnosis. And yet when he got the same diagnosis in an area that he completely understands, he said he was in a fog for a whole week. For a week, he just didn't even know what to do or what to say or who to contact. And then it clicked for him that, oh, this is what it's like for my patients. It's shock.
Mhm.
I'm going through shock. It's going to take some time, and then I'll know what to do. And it finally gave him some empathy that he desperately needed. And he was a very, at least by all accounts that I could see, was a very nice man. Didn't have a huge
Mhm.
ego, but he admitted to lacking a certain amount of empathy for his patients.
Yeah, I think that's, outside of going through that specific situation, right? Difficult to like really, we always talk about like walking in another person's shoes kind of
Exactly.
idea, right?
Yeah.
And I think it's one thing to try to project that. It's another thing to actually
Yeah.
kind of go through that situation. And I think, what can we, I came up through medical devices, right? And initially as an engineer, and then very rapidly jumped ship into product management, which is kind of help, working with engineering, R&D, and
Yeah.
manufacturing, and whomever. And in my case, physicians largely and surgeons largely, to develop and design new products and kind of move them out. You know, as you've seen with cancer specifically, are there things that industry really needs to, we've been talking about healthcare a bit, there are things that industry really needs to be thinking about that they're not, or ways in which they could they could better include patients or caregivers? I mean, what are your thoughts on that?
So many thoughts. So many thoughts.
What should
I,
we do?
well, and I think we all do this. I think we make certain assumptions based on our own experience. I think that's human nature. That's what we do. For
Mhm.
example, and this is kind of a minor example, but um, I was at this conference. I remember it was right before COVID, and this one particular hospital system was determined to have their own community in house where people would see each other face to face, and they felt like that was in the best interest of their patients. And we have a fantastic thriving online community with patients from all over the country. And so I
Mhm.
just kind of pushed back, and some doctors don't like it when I do that, but I pushed back and I said, what's in it for the patients? Do you want them to come in person so they can see you, so you can see them? And they were like, well, they'll meet other people. I'm like, they can meet other people online. You're asking them to take the time to travel to the hospital, to pay for parking, to get from parking to wherever this is going to be, and then do the reverse. And what if they need childcare? What about that? So are you going to pay for that babysitter for that hour and a half that they're gone? It felt like they weren't thinking it through. It's like,
Mhm.
why can't you have a community that is accessible for everyone? And I even said, have you just asked your patients? Have you polled them? Have you said, hey, what would you prefer? Because yes, there might be some older patients where computer
Mhm.
access might be more difficult. Although I think now with cell phones, that's no longer the case. So I really pushed back because they were making so many assumptions, and we're all guilty of doing
Mhm.
that. So you really have to. And I'm not saying that all the time we know what we want. Steve Jobs, I'm going to mutilate it, but he had this great quote about how he, customers didn't know what they wanted, until
Mhm.
they had it in their hands. And he was referring, of course, initially to the iPod and then the iPhone and etc. And there's an aspect of that too. But when you're making things perhaps more difficult for patients, you need to ask them how they feel about it.
Mhm. Yeah.
You know what I mean?
Yeah. Uh, I see that. I see that a lot.
I'm sure you do.
And I, I see that, yeah, even relative to kind of, if you will, paying customers,
Mm-hmm.
right, with organizations. And I say, okay, so you've developed this, you're showing me this prototype. I remember this one engineer, so excited. He brought in his 3 products. I just started at the company. This is 20 plus years ago. And he's like, I've developed this and I want to show it to you. And it's da 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 da. And it works like this. And I said, who have you spoken to? And he's like, these 3 people. And I'm like, okay, where do they work? All the same institution, same department. And I was like, I'm going to show you why this isn't going to work.
Mm.
And then
Wow.
the next one, and then the next one. And I'm like, I know we want to kind of keep this close to the close to the vest and keep our secrets. But you have to ask more people. You
Yeah.
have to ask more people. And you have to talk to more, right? Like you're talking, you have to ask the community, like a broad range of people who are, or whoever your community, if you have an existing, like you're saying, existing community, you have
Yeah.
to ask them what they want
Yeah. You do.
and then provide it, not what you want.
Or
That's
what
not
you
the
think they
point.
need.
Assuming things,
Yeah.
yeah, not a good plan for success.
Yeah.
And I think,
I agree.
yeah, how patients. One of the things that's really interesting that I find with the FDA has certain guidelines and rules, right? One of them is kind of around design control. One of those pieces around design control for FDA regulated devices in the United States, medical devices specifically, uh, is that you're required to do human factors, right? So you're required to have a group of individuals kind of follow whatever you put forth, your instructions for use or whatever it may be to use them. And as we as we see this like sea change happening, 20 years ago it was from inpatient to outpatient. 10 years ago it was from outpatient to ambulatory surgery centers. Now it's into the home environment, and how much
Mm-hmm.
care can we move to the home environment? Because all the studies, at least I've seen, uh, patients prefer it
Mm-hmm.
generally with the right
Yeah.
supports around it.
Right.
Uh, Payers prefer it because it's less expensive, generally speaking.
Yeah.
And people do better generally on some of the data that I've seen. And I'm sure this is not across the board, but, readmits to the emergency room, things like this
Yep.
that they've studied in small controlled groups so far. It looks positive. But as we move into the home environment, as we're required by FDA to do human factors work, who should we be talking to? I mean, is it patients and caregivers? And
If you're going
how should we think
into,
about that?
yeah, so if you're going into patients' homes, let's say my dad has early stage COPD, so let's say it's
Mm,
something for COPD. If you're going into patients' homes, you need to talk to those patients with that particular disease. You need to talk
mm,
to their family, but you also need to talk across all socioeconomic levels, different parts of the country, of course, different ethnicities and races. And I think that last part,
mhm,
the FDA and more people are becoming aware. But what I feel like I see missing all the time is the socioeconomic part. I used to live in Los
mhm,
Angeles. I live in Birmingham, Alabama now, and everything south of Birmingham is considered the Bible Belt, and it's very, very poor. And on a very sort of simplistic level, the number of women who live in the Bible Belt who get prenatal care or don't get prenatal care is
mm,
shocking. They will often wait until they are in labor and then drive to Birmingham, because here in Birmingham, it's like a healthcare mecca. I mean, I can throw a rock and hit 5 hospitals. There's a lot of healthcare options here in Birmingham, but south
mhm,
of here, there's almost nothing, even in Montgomery, which is the capital. It's just
mhm,
very, very poor. And and so I think that that is what is missing is, you know, like
Mm.
I've got a story for you. So what? So one time, um, I was through our bank partner. I was pitching to a very wealthy person who occasionally invests in startups, and he's so wealthy and so well known that we had to sign an NDA just to even have a conversation with him. It was crazy. And luckily, it was not on Zoom. It was on phone because I got so mad. I'm sure my face turned purple. I was livid because he was asking, well, I don't get this. Like, why, why would anyone need, you know, access to courses or education? I mean, if I get diagnosed with cancer, I'm just going to hop on my plane and fly to Mayo. And I lost my mind. Okay. And this guy is so connected. Like, he is related to the most wealthy and politically known family in New York. And whoever just popped into your head is probably the right family. And so he's never not had money.
Mm-hmm.
And I didn't know which was funnier, the fact that he wouldn't just, go to a cancer center right there in New York City where there are many fine cancer centers, or the fact that, oh, I'm just going to hop on my plane and fly to Mayo. I was like, and I was very tactful, but I was livid. And I just said, you know what? Most people can't fly on their plane and just, hop on their plane and fly to Mayo. See, I get discombobulated just talking about it. I got so mad. And I told this guy, I said, you don't even get it. You're like the 1% of 1%, and that
Mm-hmm.
works for you and that's great. But most
Mm-hmm.
people can't do that. That's not an option for them. And I'm not saying all academics are as bad as this guy, certainly not. But there's that sort of ivory tower effect. I remember having a conversation with a lovely woman one time who worked for a major pharmaceutical company. And she had a very similar response, not that she owned her own plane, but a very similar response
Mm-hmm.
because she lives in Manhattan and there are so many different options. And I said, but you don't represent the majority of the country.
Mm-hmm.
And so I feel like a lot of people get forgotten, really forgotten.
I think the socioeconomic thing is critically important, right? People are a bit more
Yes.
aware of some of the other dimensions we need to, DEI and
Yeah.
we need to be looking at more closely. But socioeconomics tends to get brushed to the side. It What's interesting is that in particularly uh, in the home environment, right? The idea that there can't assume there is a caregiver. We can't
That's right.
assume that they have access to good food, right? We
That's
can't
right.
assume a lot of these things. And it makes me think a little bit of high schools in some of the more economically challenged areas where they kept trying to improve the curriculum,
Yeah.
right? And then they realized that in fact it had nothing to do with the curriculum. The kids were incredibly tired, when they came to school.
Yeah.
They were working, they weren't sleeping, they were responsible for supporting part of their family, and
Yeah.
they needed things like laundry and
Yeah.
a food pantry, and because there's food insecurity and these other things that then enabled then the test scores started to go up. We could, that's a whole nother subject we're not going to cover here, but then on paper the numbers look better. How's that?
Yeah.
And I think that sometimes without talking to people, sometimes there's a tendency to look at a culture, for example, or a group of individuals like, hey, people with COPD who live in the United States, and put them in one homogeneous bucket and
Which
think
is
that there's
crazy.
one solution to that without disaggregating it and understanding the, because that's complicated, that's hard to do.
Yeah.
Um, all these like micro segments, but they need very different things in order to be, well or successful or make decisions or have care at, proper care at home.
Yeah. my heart really goes out to those people because I know what that's like. There was a time when I was raising my sister when we were evicted. I didn't have a steady income. I didn't feel
Mhm.
like myself, but I didn't know why. And I had $20 in my checking account at any given time. I mean, it was so hand to mouth that a friend's friend would buy us groceries. Just to get a new apartment, I had to lie on the application, and thankfully we got it. We moved into a studio apartment, just the two of us. And it turned out finally got diagnosed because I ended up going to the county hospital emergency room, and I had Graves' disease.
Oh,
And
wow.
and it had gotten so bad that I was borderline about to have a heart attack. And I had no idea, and I had not gone to the hospital because I didn't have health insurance.
Right.
And
It's
that's why
expensive.
I waited until it was an emergency situation. Then I ended up in the hospital for 5 days, and then eventually had radiation to burn out my thyroid. And when you're living like that, when you are literally like, okay, I have $2, what can I do with $2? How many packets of ramen noodles is that going to buy me? um, that's scary. It's that, what is it, Maslow's, I forget, hierarchy of needs.
Yeah. Hierarchy of
Yeah,
needs. Yes.
yeah, when you're right there at the bottom, when you're just trying to survive and you're not thinking weeks ahead, you're thinking one day at a time.
Mhm.
That is a very scary place to be. It's really scary. When you're saving quarters so you can do laundry, I mean, it's really, really, really tough.
Mhm.
And I don't
I
think
see.
most people understand
There's, that's a whole nother conversation.
that.
I don't think I want to entertain that just yet. Uh, I I do think that sometimes this. So I'm going to go there. I do think that this idea of bootstrapping, pull yourself up by your bootstraps, individualism, this um, in the United States, the kind of overwhelming push in that direction,
Yeah, I
it
agree.
can be sometimes really deleterious, right? Because we
Hmm.
need other people. We
We do.
need other people to help us and question us and, push us and go, what are you doing? Like, what's happening over here? Hey, can I help you with that? Um, and I do think that when people I've seen when people hold that idea, which is very much like America, right? An
Yeah,
American kind
that's
of
an
ideal
American ideal.
sometimes.
Yeah.
Yeah, that it can prevent the connection. You were talking about empathy earlier. I've seen that prevent the empathy and an emphatic response to people about what are you really going through and wanting to understand it, not looking down on it as if you could have done better. But like, where are you and how can I help and what do you need and what do we need to
Yeah.
do? And I do think that, yeah, socioeconomics, you identified a big one. I
Yeah.
can tell you that that's something that in all my years of doing marketing, we look at geography. Like, for example, we're going to look at who do we want to get in our focus groups? Who needs to be on our
Right.
advisory board? Things like that. And we look at, let's say it's just the US geography initially. We look at, let's get a mix of major academic medical centers and community hospitals and folks later on in their career and folks earlier on in their career. And we think that we've mixed, age and academic, non-academic, and some geography, and good to go. But we are there's a lot we're missing when we're doing that, and we can do a lot better, right? There are a lot of ways and means that we can connect to people now online that a lot more people are very comfortable with.
Yeah.
Um,
Yeah. Well, look at,
so,
I think a really easy place to look is reading levels. The
mm,
average reading level for Americans, and I'm sure this is going to go down, is seventh grade. If English is not your first language, it's fourth to fifth grade. And I will never understand why sometimes there are widely published papers that are meant for the general public and no one thought to think about the readability. And, a professional academic abstract is one thing, that's fine. But
Mm-hmm.
if you're writing something for the public consumption, you've got to change the grade level. And some people, and a lot of doctors think, oh, we're dumbing it down. And it's like, no, 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 you're not dumbing it down. The English language is really amazing. And you can just simplify the language. It's as simple as that sentence that you made a paragraph and making it into 5 separate sentences. I mean, writing is my background. I'm super passionate about it. And even with my own medical memoir, I and I don't leave out any of the names of medications or anything, but I was constantly aware, even with the first draft, that it came in at a 7th grade level. That was my goal. Like, I wanted to make sure
Mm-hmm.
that even someone without a high school education would understand my book, because I knew who my audience was and what and who I wanted to reach. And that gets lost, oh my gosh, all the time. I mean, sometimes my nonprofit will work with different organizations on certain projects, and before I even have to look, like, I just simplify the language, and then they'll say, oh no, it's fine, and then I'll run it through a checker. I'm like, no, this is coming in with someone who has 2 years of college minimum. And they're like, what? Yeah, I mean, it's not, that's not even a really difficult thing to do, but it's so foreign to some people, a lot of people, a lot of really well-educated people.
I think that, yeah, that's a great point about writing, because I read medical journal articles all the time for
I'm
fun.
sure
I
you
find
do.
it fascinating, and it makes complete sense to me. And then I have to say, even in my handful of years ago, my sister asked me for help with something, and I went and dug some stuff up and sent her a bunch of links to PubMed articles. She's a college graduate of an excellent university, and she said, I don't know what this means.
Yeah.
Like, what is this even? What are these things?
Yeah.
And I was like, what? So, so I think sometimes we have to be, kind of hit upside the head with, this is
Yeah.
not everyone. Everyone doesn't, it might be the world we're generally steeped in day to day, but this is not the regular community,
Yeah.
and folks who, right, normal people out there. I think the other thing that's interesting about writing and keeping it simple is it's so much easier to read, right? We've all read books, like I used to call Faulkner. It was like, swimming through mud, and not a big fan. It's just me. I'm like, you don't introduce someone on page 2, and then the next time you see them pop up is page 246, and you're like, who is this?
You could never get
Where,
away with that
where
now.
did it come from? I was like, you've got to be kidding me. And I love reading. Uh, I think there's so much we can do to be more clear. Uh, it's easy to plug it in and say, hey, it should be a 6th grade level, right? Or a 7th
Yeah.
grade level, like you're saying. And I think the other thing that people miss sometimes is that it's more clear when you take a paragraph, run-on sentence, like you're talking
Yep.
about, and you chop it into short sentences. It's easier for people to read and comprehend. And
Yeah.
I wonder if readability really takes into consideration comprehension at all. I haven't thought about that, but I was thinking about that when you were
Yeah.
talking, and that popped into my head,
Yeah.
right? Because some people can read or even speak, uh, but then understanding and comprehension is different.
That's a really, really good point. I mean, I think one of the reasons I'm so passionate about advocacy and patient education is when my sister was first diagnosed, the surgeon who did her biopsy gave me copies from his medical textbooks because I asked, because there were all these one
Mhm.
sheets on this chemotherapy, very simple, easy to understand these one sheets. But I'm like, well, that's the treatment. I want to understand the disease first. And he said,
Mhm.
and at that time, there weren't even brochures. There was nothing that existed for the type of cancer she had. So he made me all these copies. Bless him, he did. I mean, like 30 pages, and brings them in. And I looked down, and at this point, I didn't have my master's, but I did have my bachelor's. So I had a college education. And I looked down, and I felt like the stupidest person on the planet. And I ended up buying a Grey's Anatomy, which I still have, and a medical dictionary, and both of them are 2 inches thick. And I felt like I was deciphering another language from another planet. I mean, I understood Spanish better at that point. It was crazy. And I was just sitting there going, what, and writing on top of the words. And that always stuck in the back of my mind was like, why is this so hard? This should not be hard. Because when he spoke directly to me, he was very conversational.
Mm-hmm.
And another thing I'm really passionate about is avoiding euphemisms when we're talking about dying. And and I think a lot of this stuff actually needs to start in med school. Like, I think that's a good place to start. And I heard actually that USC's medical school has a class now for doctors on how to talk about dying and why you cannot use euphemisms, especially in a multicultural setting,
Mm-hmm.
because saying someone passed away in a different language may not mean the same thing as it does in English.
Right.
And I thought, well, okay, that's a good step in the right direction, because I feel like that's when you can make change, is when people are still really young and their careers are being molded, and start really early. I don't think it's as easy to convince a doctor who's been practicing for 20 years.
That is definitely, yeah, I completely agree with that. I completely agree. Yeah, you need both for different reasons.
Yeah.
For different
Yeah.
reasons, I agree with. It's interesting. I think one of the things about death and about the lack of euphemisms around it is um, there does, in my experience, and I'm really curious because you deal with a lot of different. You dealt with it personally. You are dealing with a lot of different people and having these conversations. And I had this incredibly unique experience growing up where um, my mom was a nurse. She's an RN.
Mm.
She was a nurse on the infirmary floor at the Mother House of the Sisters of St. Francis. So
Wow.
there were, yeah, super, super like niche of a niche of a niche. And no more than 30 patients at any point in time.
Oh,
And
that's nice.
the youngest nun was 89 and the oldest was 98. And like 95% of them were ambulatory. But there was this dignity to care that I haven't seen as widely. This idea that no one was cathed, people were moving, even if they were, they got ill and then they got better, they'd move them to like a commode and back. There was a lot of dignity, they got them dressed every day. People did not sit around in their pajamas all the time. Because they were nuns, right? This was like their life and who they were, and they wanted to give them this dignity at the
Yeah.
end of their lives.
I
And
love that.
they had bells. There were no buzzers or lights, or they literally had those dinner bells you see in movies. They
Oh
each had
gosh.
like a bell that they could ring, and yeah, there were no feeding tubes. There are a couple people who had to have their food pureed, and then they would
Hmm.
sit with them and feed it to them. And then when they were dying, when someone was dying, there wasn't. I think it's because they're not right. Catholic nuns, like the glory of right, the end of life, the glory of God, the going to heaven, right?
Right.
Their orientation, right, and faith and belief helps in that regard.
Right.
And uh, their friends would sit with them. Their friends would sit with them and pray, and then they all took turns sitting with them. They weren't
Oh,
hooked up to tubes and contraptions. No one was sent to the hospital to die, right? And it was, yeah, it's very different than, it's very different than how I've generally seen it take place. in hospitals. And I'm wondering, I mean, that's a whole, like, 7-day seminar right there on like how to die in the United States, right? But what can we do about that? What's a disconnect? There seems to be this, I see a lot of this prolonging death. I mean, hospice is a great step in the right direction. But a lot of this prolonging death versus prolonging life or quality of life. And I even remember 20-ish years ago sitting at this Hopkins symposium on cancer. And sitting in the room, and they said the biggest problem today is that people are surviving because we assumed they weren't going to survive. So we just barraged them with everything to try to keep them alive, not thinking they would survive. And then we got better and better and better at it, and more people survived, but their quality of life was
Terrible.
not great.
Yeah.
Right. So they had to really switch that.
And listen to
right?
that sentence you just said, right? So we're going to give them everything we can to keep them alive. But wait, they survived? Like, it's almost like your expectations and goals are completely out of alignment with each other. It's so strange to me. Oh no. Do I need to mute myself? My dog is barking. Can you hear her?
Yeah, that's okay.
Okay.
We can still hear you perfectly.
Okay, good. She'll get over it.
Yeah, my dog is locked in with my son right now. The dog goes down and across the house.
Okay, that is cute.
So she doesn't alert me.
I have a story about this. One thing I am very proud of is that I gave my sister a very good death in our home, in her bed, surrounded by people who loved her, not hooked up to anything other than oxygen. And since that time, I have seen the exact opposite. My maternal aunt had cancer, I want to say in her 60s, and somehow beat it despite her horrific lifestyle. And by horrific, I just mean she survived on cigarettes and coffee and one biscuit a day. She was extremely anorexic, scarily thin, and we're like, we couldn't even believe she survived breast cancer the first time, but I think they cut it out and she was good. It came back just with a vengeance in her 70s. And apparently her doctor told her she was dying and she didn't tell anyone. And she was put into the hospital, and without going into the background, I happened to be at the right place at the right time in the right town. And I was traveling through, and I just felt this really deep need to go see her. And I walked into this room, and she was hooked up to every possible machine you could imagine. And she had tumors in her breast, her lungs, her bones, and her liver. And I was horrified. And I went to the nurse's station, asked to speak to the charge nurse, and I said, "What's the plan here?" And she said, "What do you mean, what's the plan?" I said, "What's the plan?" I said, "She's clearly dying. What's the plan?" And she said, "Oh, we're going to put her in a nursing home tomorrow." And I was like, "What? No, she's dying. We need to find a way to help her die peacefully and without pain." And she said, "Nope, she didn't have advance directive. So, hey, we're sending her to a nursing home." And she said, "Don't you worry about it. Medicare is going to cover all of that." And I was horrified. Like, I just lost my mind. And I said, "That's not happening." And so I went back in the room, and then a nurse came in, a different nurse, and said, "You seem like you understand the severity of the situation. I want to show you something." And I said, "Go out right ahead." And she peels back the hospital gown. The tumors are coming through her skin.
Oh my gosh.
And I said, "Okay, what do we need to do?" And she said, she's going to wake up because she isn't on hospice. She's not getting palliative care. So the pain medication is going to wear off here shortly. She's going to wake up. And she said, "I need you to get her to declare a power of attorney so we can move this forward, so we can get her to hospice and get her the relief she needs." I said, "Okay, done." And sure enough, my aunt woke up within 10 minutes, screaming in pain and very lucid. but difficult to talk because she even had stuff in her mouth. And so, long story short, we communicated with a notebook. I got her to declare a power of attorney. I got that person there. And we had this really beautiful conversation through the notebook about how terrified she was of dying. And I was not close to my aunt, but she was very religious. And I just said to her, I said, why are you so scared? And she still believed in heaven. She still believed there was more than this life. And I said, well, look who's on the other side. Your dad is there. Your mother is there. My grandparents actually died within 36 hours of each other when I was 18 years old. And it was really traumatic for the family. And I said, your brother is there. My sister, her favorite niece, is there. I said, they're all waiting for you. And I told her, I said, we're going to make sure you're no longer in pain. But at this point, the only thing keeping you here is you, because you understand what I'm saying. And you have to make a decision to let go. And she had a dying wish, and she wanted to see her sisters and be reunited with her sisters. And I made that happen. I wasn't there when it happened, but I left. I made it happen, though, that night. And my cousin, actually, to her credit, made that happen. And a few hours after she saw her sisters, and I should say, to be clear, they had not been together in the same room, all three of them, in 10 years, because there was always a spat. There was always some kind of family spat going on, right? And so she just wanted to see her sisters. And a few hours after she saw them, she passed away in her sleep. Still in the hospital, but as peaceful a death as she could have had at that point. But she never, ever, ever should have been hooked up to all those machines. That should never have happened. That was awful. And it was because she was terrified of dying and wouldn't talk to anyone about it. And yet, I also blame the hospital on this. I mean, the plan to put her in a nursing home? Are you kidding me? No empathy, none whatsoever. I'm off my soapbox now.
There is a lot to unpack there. Yeah,
I know.
You and I seem to have similar views on dying and death, right? This idea of let's not prolong death.
Yeah.
If there's an opportunity to prolong living and a high quality of life, great.
Yeah.
If there's not, let's have that honest conversation.
Yeah.
So, but nobody gets. There aren't many people who get paid for that.
Yeah.
I mean, to be blunt. So the economics don't support spending a lot of time in that regard, and having a lot of those conversations and working through those things. I mean, there's, kind of E&M codes and simpler things, but I think, the economics are a little different.
I also think just how we view dying as a culture is so backwards.
There's a lot to do with our culture,
so
and how
much
we
work.
do aging and death,
and
sick care versus health
wellness
care,
yeah
right, and all of that. So I am glad to see shifts happening in that direction, and we have a long way to go.
We do.
We have a long way to go to get it right. So a lot more to do there. Well, I haven't actually teared up on my own podcast yet, so congratulations for that.
Oh, well, I can't tell. You're sucking it in really well.
Yeah. So I've become an expert at that. So that's the good news and the bad news all wrapped up. It's been it's such an important conversation to have around patients and advocates, and having real conversations with people, talking about socioeconomics, making sure we're really considering that when we think about whether it's developing programs or tech or digital health in particular, making sure that we're really developing equitable solutions across the demographics and socioeconomics. And there's a there's a lot to unpack there.
Yeah.
And more and more people are looking at it, and there's still a lot of opportunity for us to improve, right?
Oh, absolutely. I mean,
You bet.
that short time with my aunt, it couldn't have been more than even 2 hours, had such a profound effect on me, and the way that she looked, that I used to love horror films, and I used to love anything with zombies. I mean, I talked so many people into watching The Walking Dead that they should give me some of the residuals there. And I loved that stuff. But when I saw what I would consider almost a zombie in real life, I've never been able to watch that kind of graphic horror stuff ever again. I stopped watching, never finished watching The Walking Dead. I couldn't watch any of it anymore because I saw that it was actually possible that that could happen if the right circumstances and the right people were not in place. And you asked me at the top, about patient advocacy. Well, that's being an advocate.
And we need more people like you, and more patients asking the right questions, and kind of, yeah, demanding to understand things more holistically. And
Yeah.
obviously the reverse, right? People listening and hearing it and being willing to provide the right information and let people know what's really happening, not stepping away from the truth of the matter, no matter how difficult it may be to have that conversation.
Yeah.
Like super, super critical. I usually close with a couple fun questions. It seems maybe a little inappropriate. I'm gonna
No,
ask
we need some fun. We need to lighten it up.
All right, good. All right, so in doing my research about you,
Oh no.
I noticed one of the things that was super interesting was that you have run marathons, even though you said you hate running.
Yeah.
Why do that? Why do that?
Oh, I don't anymore, but I did it initially to raise money for Blue Fairy.
Um,
I did it to raise money for Blue Fairy. I had done a marathon for the Leukemia and Lymphoma Society,
mhm.
and saw how well that they managed that, and so I knew I could finish because I really truly am a terrible runner, but I finished, and so that's how I ended up. I did 6 marathons and one half marathon, 4 in LA, 2 in Vegas, and 1 in Vancouver. Haven't done one in a
That
long
is
time.
remarkable. Your why, right? People talk about like you have to have your why.
You have to have your
Like,
why.
and if
Yeah.
you're not doing things, it's because you don't have a big enough why. Your why was big enough.
Yeah, it was big enough. Yeah, one of those marathons I actually did with bronchitis. It was so miserable.
That
But
would be.
I
I've had
finished.
bronchitis. That would be miserable.
It was
That yeah,
miserable.
that is not good. The other thing I wanted to ask you about was you're a certified yoga teacher, yet you do not teach yoga.
Oh, you
Why?
really read my LinkedIn profile. Oh my goodness.
Well, I'm
Well,
super
like,
curious. I've actually thought about doing that. I love yoga.
yeah.
Yoga does a whole world of good for me and some of the things I have going on. And I've thought about getting certified, but I never wanted to teach. So I'm super curious why you decided to get certified and you don't teach.
Well, I did it backwards. So I actually did the 300-hour certification, which you're supposed to do after you've done the 200-hour for teaching. I did the 300-hour first. I saw this, probably was like a flyer on a bulletin board at my yoga studio in Burbank, California, when I was still living there. And the 300-hour does a much deeper dive into the history of yoga and much more beyond poses. It goes into mind body work, anatomy, and it all sounded really fascinating. And I remember it was this whole application process, and part of it was an interview, and I was being interviewed by the instructor, and she said, why do you want to do this if you don't even have your 200-hour and you don't teach? And I said, this is for me. I'm turning 40 in a couple weeks. This is for me. I think I really need this in my life right now and where I am. And she thought that was the best answer ever. And so I did the 300-hour first. And then when I moved to Birmingham, weeks after I moved to Birmingham, there was an opportunity to do the 200-hour. which, again, kind of did in reverse, where I'm actually learning more about the poses and why they exist. And also it was coming from a very different perspective. So I got this broad perspective of all these different kinds of yoga. And yeah. And so I did teach yoga for, I don't know, a hot minute for like a couple of months or whatever.
Would you do it again that way?
Yeah, I would. I feel so grateful they let me into that 300 hour. I was the only one who had not done that previous training. But I got so much out of it. So much out of it. Yeah, so
That's
it's just
amazing.
for me. Thank you.
Awesome. That's awesome. Any questions that you're hoping I would ask you that I haven't asked you?
My favorite color? I'm just kidding. I'm totally kidding. Hopefully your editor will edit that out. Just kidding.
That's the beauty of editing.
It is, right? Right? How come people don't believe in editing? No, I'm great. Thank you.
Great. So how can people connect with you, get a hold of you? What's the best way?
To learn more about Blue Faery, just go to bluefairy.org. And for my book, betteroffbald.com. In fact, the audio version just came out a couple weeks ago, so that's exciting. And for me personally, AndreaWilsonWoods.com. All my social media and stuff is there.
Oh, fantastic. Well, thank you, Andrea. Thank you so much for joining me today and having this great conversation. And I certainly see why this could go, why you're running over from your last one. You could have kept talking for a long time about these things.
Oh, thank you so much, Maureen.
That's it for the Message Engineer Show. Thanks so much. Like, subscribe, and all that good stuff. See you next time.